Good morning, everyone. Welcome to the webinar. We're going to start the seminar talk by Dr. Winograd in about 2 to 3 minutes. Thank you. For those of you just joining us, we're going to get started in about 1 minute. Thanks for joining us this morning. Good morning, everyone. It is my pleasure to welcome you to the final talk of our Spring 2022 Cofrin Logan Center for Addiction Research and Treatment seminar series. We're very excited to have Dr. Rachel Winograd with us today to talk about the growing concern related to the overdose crisis and some of the work that she's been doing in the state of Missouri with her partners to tackle this problem. I want to welcome everyone who's part of our CLC family this morning, and also a special welcome to friends of the center and people who are joining us from other universities and centers around the country. At the end of the talk, we will have some time for questions. It will be a moderated Q&A just because it works the best on Zoom that way. If you have your questions, and you can submit them to me in the chat window, and we will probably not have time to get to all the questions, but we will moderate those and ask them when we get to that point. I want to thank Sergey Granevsky, Archana Sundar, and Drew Rosedal for continued coordination and support for this series, and we will have another exciting calendar of seminars and brown bags for next fall and spring, so keep an eye on our Twitter page and also our event page, and I'll ask Sergey to put that in the chat whenever he has a chance. And now it's my pleasure to introduce our speaker this morning. Dr. Rachel Winograd is an associate research professor at the University of Missouri St. Louis and the Missouri Institute of Mental Health. She received her doctorate in clinical psychology from the University of Missouri in Columbia and completed her doctoral internship at the VA St. Louis healthcare system. Her scholarly, clinical, and program development interests revolve around interventions designed to save and improve lives of people who use drugs. And her primary focus is on expanding access to medical treatments, harm reduction strategies, and using person-centered approaches for those in most need of evidence-based care in Missouri. It's a real pleasure for us to hear from somebody from a neighboring state that's been a real leader on the front lines of this and the partnership she's formed. So I hope you will join me in welcoming Dr. Winograd and her presentation, Making an Impact on Our Overdose Crisis. Welcome, Rachel.
Hi, thank you so much for having me. I'm truly honored to be here and excited to talk to you all today. I have a lot to cover. We're a busy group over here in St. Louis, and so I had to pick and choose what I wanted to highlight today. It's still an ambitious lineup of slides, so bear with me. I'm going to try to give a broad overview of three main aspects of our work and to give you a taste of some of the things we're up to over here in Missouri. So a quick outline, I'm going to start by grounding us in what we're facing currently with our opioid overdose crisis, and then zoom in on through three different programs of work. One focused on harm reduction training and implementation, another focused on increasing access to medical treatment for opiate use disorder, and most recently, our community-based efforts to address growing racial disparities in overdose deaths, specifically here in the St. Louis region. Okay, so unless you've been under a rock the last 5 to 10 years, you likely have heard about our escalating opiate overdose crisis and also how it's changed over the last 20 years. You may have heard the term 3 waves or 4 waves of the overdose crisis. Now, the best national data we have that's separated by drug types so far still only goes to 2019. But you can see here that this steep orange line represents synthetic opioids, which is fentanyl. I'm going to cover that, throughout the talk. Fentanyl is a potent opioid that is made in underground labs with chemical precursors. You do not need big fields of opioid poppies to cultivate it. So it's become the dominant entity in our drug supply, and that is a very dangerous thing. So you'll also see that stimulant deaths have been increasing in the last few years, but that prescription opioids, this blue line, really leveled out and then has been decreasing recently. So that is why I do not care for the term opioid crisis. When we say opioid crisis, we still think of orange prescription pill bottles and, let's cut down on the prescription opioid supply. And the fact of the matter is we're just way past that. We are now dealing with an overdose crisis, or even potentially more accurately, a poisoning crisis. So I think it's important that we use language that mirrors what we're actually dealing with. To bring it home as well, I want to remind us that we're not just talking about graphs and data points and trend lines on a population level. These are real human beings and preventable lives lost that we are dealing with. What you're looking at here is just a quick screen grab from the first 3 weeks of death reports from 2021, just in St. Louis City last year. Our team works with local medical examiners to get these de-identified death records. And you can see, for example, just how frequently fentanyl pops up. It's present in over 95% of drug-involved deaths in our region. It dominates the drug supply. People are not dying of simple prescription opiate overdose deaths. It's more often than not a combination of drugs in people's system at the time of their death for many different reasons, sometimes intentional fentanyl ingestion, sometimes unintentional. And so we have to be very nimble in our approaches to address the current poisoning crisis. I also need to highlight the racial disparities in deaths that we have seen in Missouri in the last 5 or 6 years. Again, sadly, this figure only goes to 2019, but if it went farther, you would just see this black line going higher and higher. This is showing that Black men in Missouri are more than 4 times as likely to die of an opioid overdose death than the general combined population. This is not something that only Missouri is struggling with. We're seeing this trend nationally, and I'm going to come back to this later. But essentially what we're dealing with this overdose crisis is problems at every level. So I want to start by saying that if anyone says that there's a simple answer to this problem, or there's one bad actor, or if we just need to do this one fix in this one domain, that's going to solve it, they're being naive at best. We have problems at the system level. And when I say systems, I mean federal and state agencies, reimbursement structures, funding streams, who's in charge, who's getting what money, what incentives do they have to do different practices. We also have problems at the agency level. We have an addiction treatment field that is only very recently been exposed to a medical model. So if we're talking about a chronic condition like opiate use disorder, which can be best treated in a medical setting, how are we even supposed to prepare substance use treatment facilities that may be operating in church basements and had never dreamed of having a doctor on staff? They may have arduous program requirements for participation, and these decisions are made at an agency level. But then we have individual human beings who are clinical providers, whether it's medical staff or counselors, social workers, case managers, and they have their own internal stigma and maybe lack of knowledge and information, despite their best efforts, their goodwill, and their training. We also have problems at the patient level. people impacted by addiction don't know what to ask for. They don't know what is evidence-based treatment for their condition. They may not have the information they need, let alone the access. Maybe they don't live in a specific environment where it's ripe with resources. So though this is an overwhelming problem, it also means there's a lot of opportunities for intervention and potential leverage points for change. At the heart of my work, I continue to ask the same question, which is what is getting in the way of access to more and better care? And what are the most efficient and effective ways to reduce those barriers? At the end of the day, the more we wrap our minds around it, I really think it comes down to how we think about drug use and addiction in the first place. And maybe if we can change our hearts and minds at all of these levels, we can really start to see some systemic change. So I want to start us off here with a little exercise. So bear with me here. Everybody get out your pen and paper or a blank Word document or a notepad or something. We have a little activity. Okay, I'm going to give you a couple seconds to do that. I'm assuming you're doing it. I'm doing it. Here I am. Okay, now I want you to, at the top of your page, write down your drug of choice. You're not going to be sharing this with the class. And remember, when I say drug of choice or substance of choice, remember, caffeine is a drug, sugar is a drug, gambling is a drug, sex is a drug, shopping could be a drug. Anything that gets you going, that makes you feel a certain way, something that maybe alters your consciousness, something that you look forward to, put that up there. Now, below that, I want you to start writing down whatever comes to your mind when you think about the positive effects that that substance gives to you. What does it do for you? Remember, humans are rational beings. We don't do things for no reason. Write down your reasons. What does it bring to you? Couple more seconds. Okay. Pens down. Now, I'm not going to ask anybody to share what substance they wrote, but if anybody is willing to put some words in the chat about some positive impacts that this substance brings to you, or come off mute and shout them out, I'd love to hear them. I'll start. Practice what you preach, I'm going to say relaxation, creativity, patience, open-mindedness. Looking in the chat, energy, focus, pick me up, wakes me up, comfort, stress reduction, warmth, routine. Oh, I love these. Energy, social situation comforts, decreased boredom, stress reduction. Oh man, you guys are phenomenal. Comfort, great. Confidence. Okay, I'm going to close my window because we got to get on, but I could do this forever. Now, I want you to cross out the drug you put at the top. Put a big strike through with that. And instead, in its place, I want you to write my needs and a colon. Okay, now take a look at your needs. How does this change the way you think about your substance use? How might this change the way you think about other people's substance use? For me, I think it's really important to do this grounding when we're talking about doing clinical work with people who use drugs, when we're talking about doing programmatic work or research, remembering that people use drugs for reasons, for legitimate reasons, to fill deep needs in their minds, in their bodies, in their hearts, in their lives. So if we are working with people, or if we are advancing a certain type of research or programming that's asking people to reduce their use or stop their use, we need to acknowledge that we're taking away a route for them to fulfill core needs. And if we take that away, we need to have some ideas about what to put in its place to help people meet those needs in other ways. It also might give us a layer of compassion, empathy, and understanding for why people may choose to use drugs in certain environments. And we're going to get to this later with our local work with the Center Initiative. But sometimes the only way that people can meet some of these core needs is through drug use. They don't have the benefit of rich environmental social supports and resources. And this is the best bad option they may have. Okay, so I'm going to proceed with today's talk, but hopefully we all maybe can get a little bit of cognitive reframe about the role that drug use plays in each of our individual lives and the needs that it may fill up for us. Okay, so zooming in on 3 different programs of work, one focused on harm reduction, one focused on medical treatment for OUD, and the third one focused on addressing local racial disparities. Now, harm reduction training and implementation, this has really been a bread and butter aspect of our team's work since I started here at UMSL in 2016. The focus of our work has been on specifically about expanding access to Naloxone, the opioid overdose antidote that essentially brings people back to life. But broadly, I want to just remind us what we mean when we talk about harm reduction. So harm reduction is a philosophy, it's a framework, it's an approach for us to work with people engaging in risky behaviors. And usually we're talking about drugs and sex. Here today, we're talking about drugs. Harm reduction does not try to save or rescue anybody. It's not this big, cape on my back, I'm going to save you from this treacherous world of drug addiction. It's about meeting people where they're at, like we're familiar with from motivational interviewing, and walking alongside them. It includes abstinence as an option and goal, but it certainly does not mandate it. Harm reduction approaches are designed to support people where they are without judgment or assumption. When it comes to harm reduction strategies for drug use, it's helpful for me to think about it and talk about it in terms of a spectrum. We all might find different places on this spectrum where we go from feeling cool and comfortable to, maybe a little squeamish. And honestly, for me, especially living in Missouri, you all living in Kansas, I think we need to be okay with that and practice even a harm reduction approach for talking about harm reduction. It doesn't have to be an all or nothing type of thing. I'll work with you no matter where you're at on this spectrum. So you might think the lowest end of this spectrum, kind of our easiest, lowest hanging fruit is naloxone distribution, the overdose antidote, like I said. We give out naloxone all over the state to all different types of sectors. You might be initially, the average layperson might be most comfortable hearing that naloxone is going to paramedics and police officers, which makes sense. It's their job to save lives. It should be in their hands. Well, how do you feel about it if I'm giving it out straight to active drug users for them to reverse overdoses from each other? Does that make you a little bit more squeamish, or does that just make more sense to you as really honestly the true first responders who are most likely to be standing right there when their friend falls out from an overdose? We then have the 911 Good Samaritan laws, which are now enacted in all 50 states, providing limited immunity for people who call 911 when their friend is overdosing, basically saying, if you have a little dope in your pocket, that's okay. We're not going to arrest you. It's more important for you to call 911. We want to save a life. We have syringe service programs and needle exchanges, which is a little farther along the spectrum, giving out sterile syringes to help prevent the spread of hepatitis C, HIV, and the growth that we're seeing in injection-related infections and abscesses. Drug checking and fentanyl test strips, allowing for people to test the substances that they're putting in their body, increasingly important with fentanyl and various fentanyl analogs infiltrating our drug supply, even our stimulant supply and our pill supply. So oftentimes, if people don't know what they're putting in their body, that's a recipe for disaster, and that really increases their risk for overdose. Then we also have safe consumption spaces, the first legal ones in the United States, now operating in New York City. You may have seen some press about that over the last few months. Many other cities and states are working on this: Rhode Island, Seattle, San Francisco, Philadelphia. But so far, they're pretty controversial. They are what they sound like: safe, medically supervised places where people can go in, bring their own drugs, get sterile syringes to inject, other equipment to ingest in other ways. There's naloxone right there in case someone overdoses. There have been zero fatalities in any safe consumption spaces around the world, as long as anybody's been keeping track. But still, people really struggle with this one because it just feels like you're making it too easy. We're basically just rolling out the red carpet. And so then we even go further along the spectrum and talk about safe supply. This is acknowledging that what we are dealing with is a poisoned drug supply. And so much of the danger comes from people not knowing what they're putting in their body and not being able to access a pure, less potent supply. So there are some harm reduction advocates, many or most, who are saying, we just need to go ahead and give the people the drugs. If they're going to use anyway, let's give them a safe supply of opioids instead of making them play Russian roulette on the street multiple times a day. We're seeing pilots of this in Canada and in Europe. You could see it through a medical model where people get prescriptions for heroin-assisted treatment, or you see it in a more grassroots model where they're popping up with heroin buyers clubs, and you sort of put pure heroin out on the street and say, hey, use this instead of fentanyl or rat poison or whatever else you might be buying. Okay, so this is the spectrum of harm reduction. That being said, we do live here in Missouri, and we're only going to go so far and slowly but surely move our way along the spectrum. So our team's focus for the last few years has been pumping out naloxone and a corresponding training, really as this lowest hanging fruit. So we've had 4 grants so far, well, 5 if you count our largest one that has multiple components, including naloxone distribution, where our focus is on overdose education and naloxone distribution training for all types of sectors: community members, first responders, treatment providers, outreach workers, people who work at shelters for the unhoused, for domestic violence survivors, anyone who might come in contact with someone at risk of witnessing or experiencing an overdose. The goal with our trainings is to change people's knowledge and attitudes about drug users and about overdose itself and about naloxone as a medication. While in addition, we're not just trying to change hearts and minds, we're also giving out a crap ton of naloxone, tens of thousands of doses a year. From an empirical standpoint, my focus has been on this construct of risk compensation. This is an age-old social psych phenomenon, this idea that we all walk around with some level of risk that we're comfortable tolerating, some type of homeostasis that we want to stay at. And if we take measures to make things safer, then maybe we'll behave in riskier ways. And so this idea here is that really at the crux of people's objection to harm reduction is this fear of risk compensation, is essentially this fear of enabling. Are we going to make it so easy for people that they're just going to use more drugs or use in riskier ways? And at the end of the day, is expanding harm reduction really good for society, or is it a net negative? So we developed this scale, a very short 5-item scale called the Naloxone-related risk compensation belief scale. And we use 5 items to get at different angles of this enabling construct. We ask people, will people use more drugs? Will they be less likely to seek out treatment? Does it send the message that I'm condoning opioid misuse? Should there be a limit on the number of times that one person receives naloxone? You heard this from a police chief in Ohio saying it's a 3 strikes and you're out rule type of thing. And just broadly, is this enabling for drug users? Meaning, does it allow them to continue or increase their drug use when they otherwise might not? Now, we have multiple self-report studies from the last 10, 15 years of working with active drug users saying that people don't say that they do this, that this doesn't happen. But we need to know what people in the field think, and ideally, address their concerns about this fear of risk compensation, because it really is this brick wall when we try to get people to accept harm reduction intervention. So across 3 studies so far, I'm just going to hit the highlights here. In our work with first responders, we specifically, and this is the most captive population where we can actually do a robust evaluation in our trainings, we found that police officers have more negative attitudes toward naloxone and overdose victims than their EMS peers. We have also found, though, that by doing just a single 2 to 3 hour training on harm reduction, on the background of addiction, on naloxone, what it is and how to use it, that these can significantly improve attitudes and beliefs across both law enforcement and EMS. So training works, and that's a good thing. But when you follow up with them 6 months later, much like anything else, these improvements in attitudes and beliefs do start to regress toward baseline. They're not back where they started, but they're not as high as they were immediately fresh out of the training. So that's a signal to us that more work is needed to maintain those training benefits. Interestingly, the biggest decline in positive attitudes is seen among people who actually administered naloxone in the interim. So paramedics and police officers who actually went out into the field after we trained them and administered naloxone. And that's kind of counterintuitive. It's like, wait, you saved a life. This didn't make you feel better about it. So this is a much longer conversation about compassion fatigue, burnout, lack of role clarity, and discordance between what many first responders thought their jobs were going to be like versus what they actually may be. Another important part of this is that very few police officers actually use the naloxone that we gave them. Most of it sat on the shelf. So if anybody's wondering why, again, do I care about what first responders think about all this? I think, like I said in the beginning, how people view addiction and drug users is really critical for us to make change. And there's this bigger thread that needs untangling. How does a first responder's personal views about this stuff, how does that impact their actual behaviors on the scene at an overdose? For example, do they run and try to save someone's life, or do they walk and kind of mosey over there? Do they hit someone real hard with extra Narcans, like make them really uncomfortable and shoot them into withdrawals? Or do they try to gently bring them back to life? And how do those responses at the scene impact patient outcomes? What happens after the overdose reversal? Do people accept transport to the hospital? Do they accept a referral to treatment? Or are they so shook up by the encounter that they run off, never to be seen again? Also, just to put it succinctly, we've learned through a few years of implementing grants, including first responders, that when it comes to naloxone distribution at a mass scale, the priority should be getting it to active drug users as opposed to first responders. It's more likely that it's going to be used and save a life rather than sit on a shelf. Okay, going into the second program of work that I want to talk about. Work we've done through our teams and through statewide partnerships to increase access to medical treatment for opiate use disorder. So I'm going to come back to that in a second, but I want to actually start by talking about chronic homelessness, another growing extreme public health threat. We have over 500,000 people, probably 750,000 people now who identify as chronically homeless on any given night. Now, our prior and actually probably most common approach to addressing homelessness is this readiness, housing readiness model. People go from living on the street to maybe you can get into a shelter. If you arrive on time, they pat you down. You can't bring any of your stuff. You can't go with your partner. If you behave and follow all those rules and, are really nice the whole time, maybe you'll get an opportunity to go into congregate, or group home, group shelters, where maybe it's a little bit more friendly and amenable, but still lots of rules and boundaries and really easy to get kicked out. And then maybe if you're lucky enough, you may graduate into an independent living environment, but very few people actually get here. And then came along the housing first approach, which was like, you know what? Maybe we should address this problem of houselessness by giving people houses or homes. Let's just give people the apartment, no strings attached. And see how that impacts their ability to build their lives back up and thrive. Now, the idea with Housing First is that it prioritizes rapid and sustained access to a life-saving resource. In this case, it's housing. And everything else is a cherry on top. If you want to do drug treatment, great, we'll help you get it. If you want to do case management, awesome, we got case managers. But we're not going to require you to jump through any of these hoops in order to keep your housing. It's yours. Here are the keys, and we're here to support you. It's a very different way to look at addressing homelessness. So let's get back to drug use, opioids specifically. Let's remind ourselves of why people use opioids in the first place and what it means to develop an addiction, especially if we're talking about physical dependence as part of that addiction. So remember, when you first are using opioids in the acute use setting, you're starting feeling normal, and when you use, you get high. It feels great. You feel euphoric, but that wears off pretty quickly with repeated use. Sooner rather than later, it's that you only feel normal when you're using. And when you're not using, you're in this red zone. You feel crappy. You get dope sickness. You have the shakes. You might have diarrhea. You have anxiety. You can't sleep. So you use just to get back in this normal zone. You're not really getting high anymore. You're just using to feel normal. And that is what we mean when we talk about tolerance and withdrawal and physical dependence. The red zone is a horrible place to be. People describe it as the worst sickness they've ever experienced in their entire lives. It can last days. People are throwing up, having excruciating stomach cramps and diarrhea, cold sweats, insomnia, a lot of mental anguish. It's really just reportedly insufferable, and people will go to any lengths to avoid it. Now, we are very lucky when it comes to opiate use disorder that we have 3 medications that are FDA approved to treat opiate use disorder. Well, these 2 top ones are to treat it. Naltrexone is to prevent relapse. So a real quick refresher primer, these 3 meds are methadone. Methadone, you can think of, good time for my light to go out, is a fully lit bright light bulb that fits right in your opioid receptors and lights up. Methadone is an opioid. It sits in those receptors and it satisfies cravings and it prevents withdrawal. It's our gold standard of medical treatment. It's been around since 1972. Methadone gets a bad rap for reasons that I won't get into now, but for the purposes of this talk, it is incredibly effective at reducing illicit drug use and morbidity and mortality associated with addiction. Then we have buprenorphine, which is a partial agonist, meaning it's like a dimly lit light bulb that sits in our receptor. It's also an opioid. It satisfies those cravings and reduces those withdrawal symptoms, but there's a ceiling effect as evidenced here by this plateaued flat line. It doesn't get you high unless you were to use something else with it to amplify it, and you can't overdose on buprenorphine alone. Now, naltrexone works differently. It's an antagonist, meaning it's like a totally dull light bulb sitting in that receptor, not allowing anything else to go in. So naltrexone is FDA approved for relapse prevention, meaning if you have opioids out of your system for a long time, sometimes naltrexone can be beneficial in preventing recurrence of use. But methadone and buprenorphine, I'm not going to go into the decades of evidence they have that show their benefits. I want you to trust me on this, that these 2 are the best tools we have to reduce mortality associated with opiate use and opiate use disorder. Now, what do those medications do? Remember that graph from a couple slides ago? When you're here, you're going up and down between the red and white zone, you get on a maintenance medication like buprenorphine or methadone, and it just levels you out in the normal zone. You take it once a day. You don't have to chase it all day long like you might with fentanyl, which people might have to inject 8 to 12 times a day and really hustle and build their lives around getting that drug. With buprenorphine or methadone, you take it once a day and it allows you to stay in this normal zone and avoid the red zone. And this is really all some people need to be able to start focusing on pursuing their priorities and their goals, which are no different than the goals of you or I. Now, sadly, the treatment as usual model for opiate use disorder is still incredibly archaic. In Missouri, I'm grateful to live in a state where, there's a lot of willingness for innovation and moving things forward. But when I started doing this work in 2016, what you're seeing here on the screen was the status quo, an over-reliance on detox, or the rinse and spin, as a colleague of mine calls it. Relying too much on residential and group therapy, we treated addiction in an acute care lens rather than a chronic care lens. This is a lifetime thing people may have to deal with. This is not, a sickness that comes and goes that you can be cured of at the end of 28 days. And if buprenorphine and methadone were used, it was often as a last resort, or with real strict time limits and dosing limits. So a lot of our work the past few years has been to try to say out with the old and in with the new. So we came up with this approach that we call medication first, and we really are just lifting it from the housing first approach to chronic homelessness, prioritizing medical treatment as this life-saving resource, just like housing is for people who are unhoused. There are 4 key principles of medication first. I'm going to go through them now. The first one is simple and it makes sense. It's chronological. It's literally saying people should get medication first. They should get it as soon as possible when they present for treatment, before sitting through 4-hour assessments or treatment plans. We hear all the time about people literally puking in trash cans in an intake office trying to do an assessment. How meaningful is that data that you're getting for that assessment? Get someone to a medical provider, get them medically stabilized, and then come back for the assessment. Then maintenance treatment, maintenance pharmacotherapy specifically, should be delivered without arbitrary tapering or time limits. We have too many providers who say they're okay with buprenorphine, for example, but only for a month, or only for 2 weeks, or only at such and such dose. To be frank, who are you? Who are we to be telling people how long this medication should work for them? If it's working for them, it's working for them. Don't mess it up. Third, this is the most controversial, that psychosocial services like counseling should be offered, absolutely offered, even assertively encouraged, but not required as a condition for continuing to give someone meds. This is way too common a practice. It's all tied up, honestly, in reimbursement structures and financial incentives and things that should not be driving our clinical care. And yet here we are in our healthcare model that we have in this country. So it's too often that medication is seen as this dangling carrot. If somebody goes to their group education and they go to their group therapy, then you can get your buprenorphine or your methadone. And frankly, that sets up barriers and it costs us lives. And the last principle is do not discontinue medical treatment unless it's clearly worsening the patient's condition. And that has a lot to do with people who come in and maybe they're continuing to use methamphetamine. Maybe they're continuing to use cannabis. And honestly, if the buprenorphine or the methadone is keeping them coming back to treatment, keeping them alive, then we're going to continue it. Because what's more dangerous than using buprenorphine with methamphetamine is using fentanyl with methamphetamine. And if we stop the buprenorphine, we have to acknowledge that we're sending people out on the street to a poison supply. So I'm going to whip through. It's real easy just to work with providers across the state. We compared data from the year before we implemented the Med First approach to the initial year of implementation across 14 state-funded agencies at 56 sites throughout the state. I'm just going to gloss over the results here, but trust me when I say that when we did those comparisons, we found 5 big effects. One is that people enrolled in the state targeted response grant through the medication first approach were more likely to receive medication, get those meds sooner, get fewer psychosocial services because they were no longer required, but they were more likely to still be engaged in treatment at 1, 3, 6, and 9 months, which, remember, for a chronic condition like addiction, staying engaged long-term is a good thing. And importantly, for some, it cost the state 21% less per client per month on average. And that was purely a function of this longer retention. The longer you go, the more stable people get, the fewer services you have to give, and that decreases statewide costs rather than having this revolving door where people are just coming back every few months for the really expensive services that get clustered at the front end. So That was promising, but sadly not nearly enough. So our outcomes were better, but still not great than what we were seeing prior to MedFirst. Overdose deaths have continued to increase, recognizing that treatment is just one small piece of this puzzle. And racial disparities in overdose deaths have absolutely increased, not only in overdose deaths, but in gaps in treatment retention. So looking at some of this work taken together, it just reinforced how I started this talk, that we have these problems at each of these levels, but also there's so many systems at play, and we're being naive if we think that we can solve this through 1 or 2 grants or just focusing on addiction and drug use treatment programs. So that brings me to my most recent work, the most complicated work that I've ever been a part of. And honestly, some of the most rewarding, but also messy and vexing. So racial disparities in overdose in Missouri, as you remember from this early slide, have been growing increasingly over the last few years, but not just in Missouri. Here are some national headlines that there are many other states and cities that are seeing this exponential increase in racial disparities in overdose deaths just in the last few years. If you zoom in on St. Louis specifically, which is the epicenter of Missouri's overdose crisis, and you separate out St. Louis City from St. Louis County, look at the rate of death among Black men in St. Louis City specifically. And this goes through 2021, the most recent data we have. This is a rate of 340 deaths per 100,000 people. Now, to remind you, average death rate when we're talking about drug overdose deaths nationally these days is about 22. We don't have anybody, any group in St. Louis that is basically maybe white women in St. Louis County. But other than that, if you're looking at Black men in St. Louis City, I mean, their death rate is just astronomical. We are losing so many people and neighborhoods and families and communities. It deserves its own specific focus. This cannot be some offshoot of another statewide grant or a side project. It deserved its own attention. So I worked with community partners to try to really take their lead, many of whom felt kind of left out, to be quite honest with you, from our harm reduction focused efforts and our medication focused efforts that we've put so much muscle behind the last few years. We knew we needed to do this differently. So the pillars of our center initiative, and this has been funded by the Missouri Foundation for Health, center around the importance of advocacy, education, intervention, relationship building, and research. You can learn more about our grant here at this website, but I'm going to focus on some preliminary findings from our research led by Dr. Devin Banks here at UMSL. Please note that we're still early. This work, it takes a long time when you really want to get community input at every single stage. So we're forging ahead. We've done 2 focus groups so far with peers and outreach workers in St. Louis City serving Black people who use drugs, and community health workers specifically. So I want to run you through our preliminary findings of themes. Essentially, this all comes back to systemic racism, but we need to say, how does that manifest? What do you mean? We can't just go to treatment providers and say, there's systemic racism at play, please fix it. We need to explain what this looks like, how it manifests in their programs. And at the system level, we need to push for broad change and investment, specifically when so much of the suffering that we're seeing is a direct result of decades of disinvestment in predominantly Black communities in North St. Louis. That's manifested by these inequitable funding systems and lack of resources allocated to North St. Louis specifically. We have these vast resource deserts. If you look at maps, no healthcare, no social services, no drug treatment, no recovery housing. We also have this intense criminalized response to drugs and drug use. As much as you hear people say, we can't arrest our way out of this problem, at the end of the day, that's just rhetoric. Look at who is sitting in our jails in St. Louis. The vast majority are in there on drug possession charges. People put in for 1 day, 2 days. How disruptive is that to people's lives for having a little bit of drugs and then they can't go out on bail? I mean, these things are all related, and this is way bigger, again, than just an addiction treatment system, especially knowing how at risk people are for fatal overdose when they come out of jail or prison. People also have the lack of opportunities to build social capital and engage in healthy and adaptive activities. It's not just that there's of pain and trauma, but there's lack of opportunity for community and growth. Here's some key quotes I want to highlight, just excerpts from them. Focus group participants said, you're told all your life you're not going to amount to nothing. You're not going to amount to nothing. That's been instilled in us from generations and generations. Someone else said, how about give us a neighborhood for one thing? We'd like to be proud to go out here and have some green grass. Real pretty in our neighborhoods too. So you can see how this broad disinvestment, people don't know where to begin, but we hear loud and clear that this is not just about addiction. It's much bigger than that. When it does come to our drug supply and our treatment context, there are many barriers to accessing treatment, and that's exacerbated by systemic racism and our poison drug supply. So it's lack of availability, it's perceived cost, strict rules for who gets in and who stays in, and then poor perceived treatment and service quality once we're there. You hear people say, this is from a community health worker. We have people tell us on the regular, I'm ready to go. What can I tell them? There's no place to go. How disheartening is that when we're really funding street outreach and saying, we can get you help. And then people say, okay, you know what, Miss E, I'm ready, I'll go today. And then they can't get them in. It's like we're doomed from the start. When we're talking about how easy it is to get fentanyl, I mean, it doesn't matter whether it's at a gas station, whether it's a fool on a corner, it doesn't matter. It's right there. What do you expect? So I'm summarizing here, but taken together across these focus groups and these themes, Dr. Banks and our research team developed this model that we're calling the 4 S's, both as the key drivers of overdose and also our ticket out. So it's a lack of security, a lack of stability, a lack of safety, and a lack of survival that drives continued drug use, addiction, and overdose. But it also means that if we invest in supporting these 4 S's for Black people who use drugs, that is our light at the end of the tunnel. Here was a really illustrative quote from one of our participants. If you have no source of stability, no safety, nobody that you can go to when you're struggling with impossible situations to back you up and make you feel like you can do this without drugs, then there's no safety for you. At least you can feel safe for a little bit and get a break from this, because there's no break for most people. So remember our exercise earlier in this hour when we talked about the needs that our drug of choice fills in us. If you're sleeping on the street in the cold, without clean clothes, without a job, without a support system, and you can use a little bit of fentanyl to just take a break from that misery, from that hopelessness for a little bit, why wouldn't you? We also started getting into people's individual strategies and community strategies to cope and to heal. So we all know that people use drugs to cope, but it was really underscored in some of the language that we heard from our participants. So people talk about losing a village, that now people are just trying to find ways, like you said, to cope and to deal with life. I think there's a lot of hopelessness. You look over here and you look at community strategies. Okay, well, what do we do? Where do we even start to invest in healing these communities? And we heard over and over again the promise of working with peers and community health workers, people who have been there, were raised in these same streets, who went through these same struggles, who know what they're going through, for them to be the liaisons, the ambassadors, the connectors, the navigators. People say, we look like them. We've experienced the things that they've experienced, and we see the value in the hood. We talked about the ghetto. I wouldn't leave. I'm still living with it. I love it. There's value in it. And we have to learn how to build on it and not run from it, because we're there. So this is a good reminder, if I needed one, that this takes all kinds and people staying in all types of lanes. My lane is not to be a street outreach worker in North St. Louis and make connections with people who are so different from me. I do have a lane on the back end, on the research side, on the funding side, on the advocacy side, but we do have to work together, and that's what the Center Initiative is really allowing us to do. The consequences of these 4 S's, addiction, illicit drug trade, lack of trust with service providers because of those negative interactions, and increased feelings of hopelessness. This was a really powerful quote from our transcripts. I didn't go to school because I felt like I'm not going to be alive when I'm 21. Boy, you want me to spend 4 years of my life doing this high school? I'm not even going to be alive when I leave here. It's a waste of my time. That's how I felt. So I'm going to sell dope because it's at least like I can get something now. And when I die later, at least I had died with a little something more than what I had. So this is the model that we're working with systemic racism as this background driver, but getting more specific in how that manifests, all contributing to the lack of perceived safety, security, stability, and survival that Black people who use drugs, who are at highest risk of overdose death in St. Louis, are experiencing. So yes, we have hopelessness and mistrust, but we can also get out of this by building hope and trust. These things are all related: our drug trade, and the addiction crisis, individual and community strategies for resilience, and advocating for more investment in reducing barriers, and advocating for a safer supply. So what are we doing with these insights? Our priorities on center right now are threefold, but we're open to changing them because things are iterating constantly. We want to change the narrative about drug use and people who use drugs to increase urgency, but also increase hope and reduce stigma. We're trying to promote safer use through harm reduction tools, not just naloxone, but fentanyl test strips, advocating for legal syringe access in Missouri, and drug checking. We're also working to increase service options, not only by improving the existing programs that we have in operation, but building new systems and new programs that are more based in relationship-based healing, peer-to-peer connection, and community pride. So, final takeaways and looking ahead. I know I've done, a broad buffet of some of the things we're up to, but if you remember anything from this talk, I want you to remember these three things. Fentanyl is increasingly dominating our drug supply. We are not dealing with the same overdose crisis we were dealing with 10 years ago. Our policies cannot keep up, matter of fact. We need to ramp up our harm reduction responses accordingly, prioritizing working with people actively using drugs. They are the center of this crisis, literally, and anything done around them that doesn't involve them and equip them with the tools to save lives is a less efficient use of our time and resources. We also know that low threshold medical treatment programs can work. We're seeing examples in states across the country, and we see it right here at home in Missouri, but they need to get more system level supports to scale up. The main barrier right now is financial. Our treatment systems are not designed to be low threshold. So they are not going to be low threshold just on goodwill alone. They have to be financially incentivized to do so, and that involves changes to reimbursement structures. We also, lastly, need robust ecosystems of substance use services in every community. I've learned a lot over the past few years. I realize that it is not effective to just stay on one message and say, we need this or we need just this. That is myopic. That is short-sighted. We need all of it and more. There's no single answer to this overdose crisis. There's a lot of things that need to happen, and we need to meet people where they're at, meaning with active harm reduction outreach and drop-in centers, with residential treatment, with outpatient treatment, with low threshold outpatient treatment, with recovery housing, with transition housing, with recovery community centers for the long term. We need it all, and we need it at scale. And right now, what we have is just a drop in the bucket. Those services need to center equity, relationship, and dignity for the people they're purporting to help. So I want to thank my funders and my fabulous staff and teams who are doing this work day to day. Here's an example of one of the public service announcements we've put out through our grant, and I will end it there. Thank you all for your time and attention.
So thank you very much, Rachel. It's great to hear what is going on in our neighboring state, and I think that although Kansas City may not be at the same pace as what's happening in St. Louis, there certainly are challenges that we're facing on the other side of the state of Missouri as well, closer to Kansas. I'll remind everyone that we are going to do a moderated Q&A for the next few minutes here. If you have questions, please put them in the chat. We do have one question that came in during the presentation when you were talking about people being on medications and then not requiring them to stop using other substances at the same time. And so we have a question here is, what are the medications you would expect the people who use drugs to continue to have access to? Is it drugs that they've already used? And I wonder if what the implication there is, are they going to potentially start using other substances that they had not used in the past once they get stable from their use of opioids? Do you have any comments on that?
Yeah, I mean, that's a great question. And I think the short answer is all of the above. And this is tricky because there's so much discretion for individual medical providers. And you have, for every medical director at these treatment systems, they might have a different rule book. But it can manifest in looking like the example that I used, where people might come in using both opioids and stimulants, and maybe the MAT, the buprenorphine, is helping with their opioid use, but it's not really helping with their stimulant use. And so this model is saying, keep treating them for their opioid use, and then you can start working on their stimulant use, which sadly, we don't have great medications to help with at this time. But it can also be about co-prescribed medications. So there are a lot of physicians who are really squeamish about giving people buprenorphine if they have a prescription for a benzodiazepine like Xanax or Valium, for example. The FDA came out in 2018 actually and said, we're realizing that this drug landscape is changing. And even if people are still taking benzos, please keep giving them their buprenorphine. It's much safer than the alternative. You also see people, on Klonopin or gabapentin or trazodone, different comfort medications or like, lower grade meds to address neuropathic pain or body aches or things that come up. And essentially from a medication first approach, it's like, as long as this medication is not causing harm, as long as they're doing better on it than off it, then let's keep giving it to them. And we'll just work on those other drugs and medications slowly through a harm reduction lens.
Great. I'm going to turn it over to our center director, Rich Shee. He can unmute himself. He has a question for you about risk compensation.
Hi, Rachel. Thank you for that presentation. That was wonderful. Kind of returning to something you mentioned kind of in the first third of your presentation, which was risk compensation. So I'm wondering whether you or you're familiar with any literature that actually can speak to whether there actually is risk compensation that might result from some certain types of harm reduction strategies. So I don't know that literature at all. So if there was any research that actually looks at, do we see changes in substance use that might result from harm reduction strategies?
No, great question. I was flipping through my extra slides because I was wondering if I put that slide in there, but I didn't.
And then I just add one other thing to that, which is that I think as it relates to kind of public opinion related to harm reduction strategies, part of it is risk compensation, right? But my sense is that it really has to do with kind of opinions about substance use, right? So not necessarily whether it will result in risk compensation, but kind of, I guess, puritanical, to kind of give it a label, puritanical beliefs about whether substance use is acceptable at all. So kind of, can you speak to kind of, and I suspect you have some thoughts about this, like, can you speak to kind of, even if there's compelling evidence that risk compensation, or at least not substantial risk compensation occurs resulting from harm reduction strategies, do you expect that to move the needle as it relates to public opinions on harm reduction strategies because perhaps the prevalence of like underlying puritanical attitudes about substance use?
I love this question. This gets like straight to the heart of it. I couldn't have said it better myself. And how much time do we have? I mean, honestly, okay, let me try here. So to your first question, there has been ample evidence now that drug use does not increase when you give people more access to naloxone specifically. There have been similar studies with syringe access programs, and rather people are more likely to enter substance use treatment. There's emerging work to find similar, looking at similar impacts of safe consumption spaces. Basically, like, it's not just the naloxone, it's not just the needles that people are giving out. You're opening a door. You're giving a setting for someone to come into. There's a couch, there's a cup of coffee, there's a non-judgmental face. And the healing impact that can have on people actively using drugs. It's about so much more than just the harm reduction tool that you're giving them in the moment. So, you will have skeptics and critics. There is, some research out there saying like, well, no, we did these focus groups with drug users, and they said if you gave them naloxone, they'd use more. But we do not have like an actual EMA study, for example, or something looking at drug samples, testing, physiologically, looking longitudinally if people do use more. But part of this is like a self-report, a trust, and good faith, and like this is the right thing to do. And even if there is a tiny subset of people who do use more, at the end of the day, just like there might be a small subset of people who, when they wear bicycle helmets, might ride closer to a car. At the end of the day, bicycle helmets are still a net positive. They're still saving lives. And that's how we have to view naloxone, not withhold it based on these unfounded fears of enabling. But to your point, this is absolutely rooted in puritanical thought. I mean, same that we have for sex. This idea that people would use drugs for pleasure, but that's not right. That's breaking the rules. I don't use drugs. I follow the rules. How come you can't just be like me? And now we're just going to make it safer and easier for them to do that? I'm morally opposed to it at my core. And that's similar, that's related to the opposition to buprenorphine and methadone. The fact that people could get a feeling of warm fuzzies, from this medication, like it just makes people bristle. It doesn't align with their beliefs. And there's no matter how much data or evidence you throw at them, like you just can't get past this, that like you're not supposed to do drugs. You're not supposed to take things that give you pleasure, unnaturally. And that is a tough one. I think there are different ways to try to change people's minds when it comes to increasing receptivity to harm reduction. One angle is the science and data angle, saying like, this just doesn't happen. This is unfounded. Data doesn't bear out. Another angle is to get at heartstrings, and some of the things we've done in our trainings is, cut out some slides with graphs and meta-analyses and add time for a panel of people who are on buprenorphine or on methadone to see these real human faces and these real, stories behind harm reduction and medical treatment, to humanize it a bit and try to get people to take down those puritanical walls. Because you're right, I think that's a huge barrier, across all settings.
So we are right up at 11:30, so I understand if people have to leave. I do want to ask one final question here. There's a question by Sarah Bibler, but I think you just kind of addressed some of that in your last answer. But I want to go back to a question by Justin Strickland from Johns Hopkins, where he's talking about, when we think about systemic change, how do we reconcile the fact that most of the programs are occurring locally with small grants or state money, and that can dry out or can go away rather rapidly, with the fact that real systemic change is going to happen at a scalable level, whether it's large scale funding, federal, whatever. How do we get that heavy lift? How do we get there?
Well, we're out of time, Michael. No, I mean, I don't know. I was not trained to do this work. I've kind of fallen backwards into implementation science effectively, and trying to do it, scrappy and whatever I have in front of me. But more and more, it's disillusioning how much of this comes back to systems and funding structures and reimbursement. So I do a lot of close work with my single state agency, the Department of Mental Health, because they're and have done a lot of learning and listening to try to see what is within a state's control, what is within an individual program's control versus at the control of at the federal level. And I think you need smart people at every level advocating for change, and people need to be talking to each other across those levels. But for me right now, I try to keep my foot in federal advocacy efforts, but the bulk of my time is focusing locally and at the state level, because there is a significant amount of change that we can still push for, even within the bounds of our state boundaries.
Great. So with that, we're going to wrap up. I did see somebody post a message in the chat. I just want to acknowledge that one of the donors of our center, Gayla Guthrie, is here in our webinar today. And it was a supporter of the Patrick Guthrie Hawks for Hope Fund, which is supporting student research here in our Cofrin Logan Center. So it's wonderful to have you with us, Gayla. And I hope you enjoyed the presentation today. With that, we're going to wrap up our Spring 2022 series of seminars. In the fall, we will have another slate of speakers. We are planning on going back to in-person here at KU, but we're working with our partners to make it a hybrid format that'll be engaging so we can continue to offer these opportunities for people that join us from all over the country. We're really excited to have you, and I hope you have a wonderful rest of your day. And thank you so much to Rachel for your presentation today.
Thanks for having me. It was a blast.